Welcome back, everybody. We'll continue our discussion on management of diabetes in pregnancy, clinical update. Today's topic is on complications during pregnancy and birth. Now, why is identifying gestational diabetes mellitus important? Identifying GDM is important in order to not only prevent and minimize complications during pregnancy and birth, but also to prevent and minimize long-term complications in both the mother and the child. Now, overt maternal diabetes mellitus can adversely influence intrauterine development. Spontaneous abortions and major congenital anomalies may occur in the first trimester. Excessive fetal growth, neonatal hypoglycemia, jaundice, polycythemia, and stillbirth may occur during the second and third trimesters. Now, excess birth defects are generally occurring in cases of hyperglycemia diagnosed during pregnancies that meets criteria for overt diabetes mellitus. The frequency of other adverse outcomes across the full range of maternal hyperglycemia that defines true GDM is difficult to determine. The reason is simple. Women in the upper part of that range almost always receive some form of treatment. Results from the Hyperglycemia and Adverse Pregnancy Outcome Study, or HAPO, provides useful insights into the frequency of perinatal complications in women with relatively mild GDM in the absence of treatment. In the HAPO study, women found to have fasting plasma glucose levels of greater than 5.8 millimoles per liter or a glucose level of greater than 11.1 millimoles per liter on the 75-gram 2-hour OGTT were referred for treatment of GDM. Women with lower glucose levels than this threshold received no diagnosis or care related to their glycemic control. Let's look at the table of perinatal outcomes in the HAPO study when IADPSG criteria for GDM are applied. Retrospective application of the new IADPSG criteria for GDM to these untreated women revealed statistically significant increases in 10 different adverse perinatal outcomes in women who had GDM compared with those who did not. Although the relative increase in risk ranged from 70 to 202% across the 10 complications, the absolute risk, the difference in complication rates between the GDM and control groups was not more than 11% for any complication. Similar patterns have been observed in many smaller studies. For example, 10% absolute risk of cesarean delivery and 14% absolute risk of macrosomia in women with untreated borderline gestational diabetes mellitus in the Toronto Tri-Hospital GDM project. The main conclusion is that diagnosis of GDM imparts some excess risk of perinatal complications. However, only a minority of pregnancies have an adverse outcome that could be attributed to GDM. This fact will become important when approaches to antepartum management are discussed later. The question we need to answer is this: is diagnosing and treating GDM cost-effective? Traditionally, most of the evidence about the antenatal and perinatal benefits of diagnosing and treating GDM have come from a mix of clinical observations and non-randomized treatment trials. As a result, expert bodies have made a wide range of recommendations about the importance of diagnosing and treating GDM. At one end of the spectrum are organizations that recommend widespread or universal screening for GDM and step care treatment of women with the disease. At the other end of the spectrum are groups that have questioned the cost-effectiveness of detecting GDM at all. Two randomized clinical trials have provided evidence that diagnosing and treating GDM can have statistically significant beneficial effects, albeit in a relatively small fraction of patients. These are the Australian Carbohydrate Intolerance Study, or ACHOIS, and the Maternal Fetal Medical Unit Network Study. In the ACHOIS study, a 75-gram OGTT was performed between 16 and 30 weeks of gestation, and fasting plasma glucose levels of less than 7.8 millimoles or 2-hour glucose levels between 7.8 to 11.0 millimoles were used as the criteria for the diagnosis of GDM. Women with GDM were randomly allocated to usual care, which is composed of patients and providers blinded to the OGTT results, or intervention. In the intervention group, patients and providers were aware of the OGTT results. Treatment included individualized nutrition advice and glucose self-monitoring. Exogenous insulin was given when glucose levels exceeded pre-specified target. The intervention group had a lower rate of serious perinatal complications, 1% versus 4%, mostly shoulder dystocia, but a higher rate of admissions to the neonatal intensive care unit, 71% versus 61%. In a study from the Maternal Fetal Medical Units Network in the USA, a 100-gram OGTT was performed in women between 24 and 30 weeks of gestation. The criteria for the diagnosis of GDM were a fasting plasma glucose level less than 5.3 millimoles per liter and at least 2 timed glucose values that met or exceeded set threshold: 1 hour of 10 millimoles per liter, 2 hours of 8.6 millimoles per liter, and 3 hours of 7.8 millimoles per liter. Patients were randomly allocated to usual care, blinded to the diagnosis, or intervention, as in the ACH-OIS study. A composite of clinically significant perinatal outcomes, including death, trauma, jaundice, hypoglycemia, or elevated C-peptide levels in the offspring, occurred at similar frequencies in the two groups. Rates of shoulder dystocia were reduced in the intervention group, 1.5% versus 4%, similar to the results of the ACH-OIS study. In both randomized clinical trials, intervention was associated with significant reductions in mean birth weights, about 100 to 150 grams, in rates of infants that were born large for gestational age or that weighed greater than 4,000 grams at birth, and in rates of maternal hypertensive disorders. For these last three adverse outcomes, absolute differences in rates between groups were 6 to 10%. Taken together, these studies and the meta-analysis that included them and three smaller studies reveal a consistent pattern. 1. Diagnosing GDM and treating it using nutritional advice, glucose self-monitoring, and if required, exogenous insulin lowers the relative risk of fetal overgrowth, shoulder dystocia, and maternal hypertensive disorders. 2. However, only a small fraction of pregnancies benefit, since most pregnancies do not incur any adverse perinatal outcomes in the absence of treatment, and some pregnancies incur them despite treatment. Next, a much larger body of evidence exists regarding the effect of intensifying treatment via nutritional therapy once GDM has been diagnosed, as reviewed in the meta-analysis by Howard et al. The methods of intensification varies considerably across the 13 analyzed studies and includes 1. Insulin treatment versus diet alone, 2. Different intensities of insulin, 3. Insulin versus aerobic exercise, 4. Glucose monitoring at visits versus glucose self-monitoring by patients, 5. More versus less frequent glucose self-monitoring, 6. Glucose self-monitoring versus continuous glucose monitoring, 7. Therapy adjustments at visits versus adjustments using telemedicine, 8. Caloric restriction versus unrestricted diets with insulin treatment, and lastly, the use of ultrasonography to guide decisions on insulin treatment. There are major weaknesses in the study of GDM. First, the studies were generally small, between 41 to 340 individuals each. As might be expected, it was difficult to identify uniform or consistent findings across this heterogeneous group of studies in the meta-analysis. Rates of shoulder dystocia, which was reported in 5 of the 13 studies, were reduced significantly in the intervention group, around 3% absolute risk reduction. There was a tendency for reduction in the rate of large for gestational age babies in the intervention group that did not reach statistical significance and represent only a 4% absolute risk reduction overall. No important difference in rates of cesarean delivery, birth trauma, macrosomia, or perinatal mortality were found. Thus, As is true for diagnosing and treating GDM, intensifying treatment can benefit a relatively small but potentially important subset of patients. The information presented highlights another major weakness in the field of GDM. Intensive monitoring and, to a lesser extent, pharmacological treatments are applied to a large number of patients to improve outcomes in a relative few. Even if this approach could be shown to be cost-effective, it is almost certainly inefficient. In truth, when it comes to perinatal complications, GDM is more of a risk factor than a disease. A very great need exists for more precise methods to identify the subset of pregnant women with GDM who are the highest risk for perinatal complications so that the most intensive monitoring and treatment efforts can be directed at them. Maternal glucose measurements are a very crude tool in this regard. This ends our discussion on complications during pregnancy and birth. See you next time when we discuss long-term consequences of GDM to the mother.